You know, those first few days with the new baby, it's absolutely incredible, right? But you're also kind of on high alert for every little thing.
Definitely. Everything seems new and potentially worrying.
Yeah, and one of the most common things parents notice, and it can cause a bit of worry, is a yellow tinge to their baby's skin.
Ah, yes, jaundice. Very common.
Exactly. So today on the deep dive, we're focusing right on that neonatal jaundice. We've gathered key info from neonatal care guidelines
These guidelines, yeah.
to give you a clear, efficient understanding of this really, really frequent newborn issue.
Hmm.
Our goal is basically to break down what causes it, who's more at risk, how it's identified, and, what the management looks like so you feel knowledgeable and prepared.
Sounds good. Let's dive in.
Okay, let's get started. Neonatal jaundice.
Yeah.
So what exactly are we seeing when a baby looks, a little yellow?
Well, what you're seeing is that yellowing of the newborn skin and also the whites of their eyes, the sclera. And it happens because there's an elevated level of a yellow pigment called bilirubin in their blood.
Bilirubin. Right.
Newborns just tend to have higher bilirubin levels. They have a greater concentration of red blood cells to start with, and these cells also have a shorter lifespan compared to adults.
So it's like a lot of red blood cells are breaking down pretty quickly all at once.
Precisely, yeah. When these red blood cells break down, they release a form of bilirubin called unconjugated bilirubin.
Conjugated.
Yep. And this unconjugated bilirubin then travels in the bloodstream, but it needs help, so it binds to a protein called albumin.
Okay.
Now, the liver has the really crucial job of taking this unconjugated bilirubin and processing it. It turns it into a conjugated form.
Conjugated, right.
And that form can then be excreted from the body, mostly in the stool.
Okay, so a simple way maybe to think about it is like bilirubin is the yellow pigment byproduct from old red blood cells.
Exactly.
And the baby's liver is still kind of learning to handle it efficiently.
That's a perfect way to put it. The liver's just getting up to speed.
That makes a lot of sense. So, okay, what are the different reasons this bilirubin might build up then? What triggers the increase?
We can generally group the causes based on when the jaundice appears after birth and also the specific type of bilirubin that's elevated.
Right.
A very, very common type is physiological jaundice.
Physiological. Okay.
This typically becomes noticeable around, say, day 2 or 3 after birth.
Right.
And it's simply due to that increased breakdown of red blood cells we just talked about, combined with the fact that the baby's liver function is still maturing.
So it's just normal development in a way.
In most cases, yes. It usually resolves naturally, fades away by about day 10.
Okay, so that's the kind we sort of expect to see in many newborns. But what if the yellowing shows up much earlier? Or, lasts significantly longer?
Exactly. That's when we need to pay closer attention. If jaundice appears within the first 24 hours of life, we call that early neonatal jaundice.
First 24 hours.
Okay. And this can sometimes point to a more serious underlying cause that needs prompt investigation.
Like what?
Here we start thinking about things like hemolytic disorders.
Hemolytic, meaning blood cell breakdown.
Exactly, faster breakdown, like ABO or Rh incompatibility between the mother and baby, or G6PD deficiency, that's a genetic condition affecting red blood cells.
Okay.
Infections too, whether they're acquired before birth, congenitally, or after birth, and even certain maternal autoimmune conditions can trigger it early.
Wow, okay.
And then there are some rarer genetic syndromes like Crigler-Najjar, Dubin-Johnson, Gilbert syndromes that affect how bilirubin is processed.
That's quite a range of possibilities just for that early onset. And what about when the yellow color just hangs around for ages?
Right, that's what we call prolonged jaundice. We define it as lasting more than 14 days in a baby born at term, or more than 21 days in a preterm baby.
Longer for preemies, makes sense.
Yeah. In these cases, we look for different things. Could be infections again, maybe a urinary tract infection, endocrine issues like hypothyroidism or hyperpituitarism.
Hormones.
Yes. Metabolic disorders like galactosaemia. Interestingly, breast milk itself can sometimes contribute to prolonged jaundice.
Really? Breast milk?
Yeah, sometimes called breast milk jaundice. It usually resolves, though, typically by around 6 weeks.
Okay.
And we also need to consider GI causes gastrointestinal things like biliary atresia, which is serious, or a colodocal cyst, or neonatal hepatitis.
Biliary atresia sounds worrying.
It is. It involves the bile ducts. Needs early detection.
Okay. And you also mentioned conjugated hyperbilirubinemia earlier. How's that different from what we've mostly been talking about?
Good question. So unconjugated is before the liver processes it. Conjugated hyperbilirubinemia means the liver has actually processed the bilirubin into that conjugated form.
Okay, it did its job.
It did its job, but there's still a problem with getting it out of the body properly with excretion.
Ah, a blockage somewhere down the line.
Potentially, yeah. This can be caused by infections. Sometimes it's related to IV feeding, parenteral nutrition. Certain metabolic problems like alpha-1 antitrypsin deficiency.
Right.
Those GI issues we mentioned, particularly biliary atresia. And even endocrine factors like hypothyroidism again.
This breakdown by timing is really helpful. So just to recap for me, and for you listening, maybe a little memory aid here. We have physiological jaundice, often poster, or later, like day 2, 3. Then early jaundice, first 24 hours, could be emergency signal.
Definitely needs checking urgently.
And prolonged jaundice, lasting weeks, needs further probing to find the cause. Does that sound about right?
That's an excellent way to remember it. PEP, physiological, early, prolonged.
Okay, great. So we understand what it is and the various reasons behind it. Are there certain newborns who are just more predisposed? What are the key risk factors we should know?
Yes, definitely. Several factors can increase a baby's risk. Babies with low birth weight are more vulnerable, whether they're born prematurely or just small for their gestational age.
Okay, smaller babies.
Breastfed infants can sometimes have a slightly higher risk, especially in the early days if feeding isn't quite established yet.
Why is that?
Well, early and frequent breastfeeding helps establish milk supply quickly, and that actually helps bilirubin excretion. So delays in feeding getting going can increase the risk initially.
Right, makes sense. Colostrum is important.
Very. Also, if a baby has a sibling who previously had jaundice that needed phototherapy treatment, their risk is higher too.
Family history, okay.
Visible jaundice within the first 24 hours, as we said, that's a big risk factor itself.
That's like the E and PEP.
Exactly. Babies born to mothers with diabetes also have a higher risk. Male infants, interestingly.
Boys more than girls.
Seems so statistically. And babies of East Asian ethnicity.
Okay.
And one more slightly unusual one, populations living at high altitudes seem to have a slightly increased risk as well.
Huh. Altitude. Okay. So it's kind of a mix of factors, isn't it? Immaturity, feeding, family history, genetics, demographics.
Precisely. You look at the whole picture for the newborn.
Right. We've touched on the process of bilirubin building up, but can we go a bit deeper into the why? What's the actual, physiological mechanism, the pathophysiology?
Sure. The fundamental reason is an imbalance between how much bilirubin is being produced and the baby's ability to clear it, to eliminate it.
Production versus elimination.
Exactly. We've said the breakdown of red blood cells is the source, and newborns just have a higher turnover of these cells, more production.
Okay.
At the same time, their livers, which have to do the processing job, are still developing. They might not have the full capacity of the necessary enzymes yet.
The enzymes aren't fully kicked in.
Right. Particularly one called glucuronyltransferase. It's crucial for changing the bilirubin into a form the body can easily get rid of that conjugation step we talked about.
Glucuronyltransferase. Got it.
So this relative immaturity of the liver's processing power can create a bottleneck. Bilirubin backs up, accumulates in the bloodstream.
And that's when we see the yellowing.
That's when we see the jaundice.
So it's a two-pronged issue.
Yeah.
Really. A higher load needing processing and a less efficient system to handle that load.
Exactly that. You've got it.
Okay. So when a newborn does present with jaundice, how do doctors or midwives figure out the underlying cause? What else could it be besides that common physiological type? This sounds like what's called a differential diagnosis.
That's right, differential diagnosis. While physiological jaundice is definitely the most common, it's essential we consider other possibilities.
Okay.
Breast milk jaundice, as we mentioned, is one. Then there are those hemolytic disorders where red cells break down too fast.
Right, like the ABO incompatibility.
Yes. We also need to think about actual liver diseases, though rarer, and those metabolic disorders that can interfere with bilirubin processing.
So tests are needed to narrow it down.
Absolutely. Investigations are key to pinpointing the specific cause.
Speaking of how common it is, what does the overall picture look like here in the UK? What's the epidemiology?
It is indeed very, very common in the UK. Neonatal jaundice affects approximately 60%, that's 60 of newborns born at term.
Wow, more than half.
Yeah. And an even higher percentage, around 80% of preterm newborns.
80% of preemies.
Mm-hmm. Fortunately, the majority of these cases are mild. They don't need specific treatment.
Okay, that's reassuring.
However, we do see that roughly 5% of term infants and up to 10% 1 in 10 of preterm infants will need some form of intervention, usually phototherapy.
Okay.
And it's quite typical, as we touched on, for breastfed babies to have jaundice that lasts a bit longer. Maybe 10% might still show some yellowing at 1 month old.
So it really is super common.
It really underscores how frequently we encounter this in the newborn period. It's almost expected to some degree.
Right. It sounds like seeing some level of jaundice in a newborn is almost the baseline scenario. So what are the key signs and symptoms parents and healthcare professionals should be looking out for? How does a baby with jaundice typically present?
Well, the most obvious sign is that characteristic yellowing. Skin, whites of the eyes, the sclera, sometimes even inside the mouth, the mucous membranes.
Okay. And does it appear everywhere at once?
Usually not. It typically starts on the face and forehead and then gradually progresses down the body, chest, abdomen, and finally arms and legs. Cephalocaudal progression, we call it.
Head to toe, basically.
Head to toe, yeah. If the jaundice becomes more pronounced, more intense, the baby might seem more sleepy or lethargic than usual.
Okay, less active.
Yes. Poor feeding can also be a sign of more intense jaundice. Maybe not waking for feeds or tiring easily.
Right.
And crucially, this is really important in any neurological signs. Things like changes in muscle tone, maybe becoming unusually floppy or suddenly quite stiff.
Oh, okay.
Or seizures, or a really high-pitched, unusual cry. These are very concerning. They require immediate medical attention because of the potential risk of kernicterus.
Kernicterus. We'll come back to that. Sounds serious.
Very serious brain issue, yes. It's also important to look out for signs that might suggest that conjugated hyperbilirubinemia we talked about.
The blockage type.
Kind of. Things like unusually dark urine, like tea-colored, and very pale or clay-colored stools.
Pale poo and dark wee.
Exactly. Those can indicate conditions like hepatitis or that biliary atresia where the conjugated bilirubin isn't getting out properly.
So it's not just how yellow, but also how the baby's acting, feeding, and even their nappy contents that give clues.
Absolutely. The whole clinical picture, the pattern, progression, associated symptoms, it all helps guide the assessment.
Okay. So when a baby is jaundiced, what are the first steps? How do we figure out the cause and what to do? What investigations are typically involved?
Right. The primary investigation is always to measure the level of bilirubin in the baby's blood.
Check the levels.
Check the levels. This can be done a couple of ways. Either non-invasively through the skin, using a device called a transcutaneous bilirubinometer, a TCB.
Like a little scanner on the forehead.
Often, yes. Or by taking a blood sample for a serum bilirubin measurement. SBR, we often call it.
Okay, TCB or SBR. When do you use which?
Generally, for moderately jaundiced, otherwise healthy babies around day 2 or 3, a TCB is often fine as a screening tool.
Quick and easy.
Exactly. But if a baby is unwell, or if the jaundice appears within that first 24 hours, or if it's prolonged jaundice.
The PEP situations again.
Yes. Then we typically prefer a serum bilirubin measurement, the SBR. That's considered the gold standard. We'd also go for an SBR if the TCB reading is very high, say above 250 micromoles per liter.
Okay. Are there other specific triggers for checking levels?
Definitely. Any jaundice in the first 24 hours always gets checked urgently.
Right.
Also, if a baby was born before 35 weeks gestation, they're monitored more closely. And if their bilirubin levels are getting close to the thresholds where we might need to start treatment. We don't really use older devices called icterometers anymore. And routine screening for bilirubin in babies who don't look jaundiced isn't typically recommended. Makes sense. But it is really important to measure the conjugated bilirubin level, specifically in babies who might have an enlarged liver or spleen hepatosplenomegaly, or those little red or purple spots called petechiae, or if their jaundice is prolonged.
To check for that blockage issue.
Exactly.
And beyond just the bilirubin levels, what other tests might be needed to track down the cause?
Right. Depending on the clinical picture, we might need more tests. Liver function tests, LFTs, if we suspect a liver problem like hepatitis or cholestasis, that's a problem with bile flow. If the baby's unwell or the jaundice was very early, we'd likely do an infection screen. That could mean blood cultures, urine cultures, maybe tests for specific infections like the torch group.
Torch screen.
Yeah. To investigate for hemolysis, that rapid breakdown of red cells, we'd check babies and mom's blood types, RH status, do a direct antiglobulin test, or DDEAT, often called a Coombs test.
Coombs test, right.
Check the baby's red cell count, reticulocyte count that tells us how fast new red cells are being made, and look at a blood film under the microscope. Sometimes specific enzyme tests too, like for G6PD.
Okay.
If we suspect galactosaemia, that metabolic disorder, we might test urine for reducing substances, especially if they're having milk feeds, and we'd usually check thyroid function too, TFTs.
Right.
And then for those cases of cholestatic jaundice where we're worried about bile flow blockage, we might need imaging, ultrasound of the liver and biliary system, maybe a HIDS scan to see how bile is flowing, and in complex cases, sometimes a liver biopsy or even surgical exploration might be needed to tell the difference between, say, hepatitis and biliary atresia.
Wow, that's a comprehensive workup, potentially.
Mhm.
So once the levels are known, maybe the cause identified, what's the typical approach to managing neonatal jaundice? What treatments are there?
Management really depends on several key things. The bilirubin level itself, the baby's gestational age, how fast the level is rising, and their overall condition. Close monitoring of bilirubin levels is crucial. There are charts and guidelines that show specific thresholds for when to consider treatment.
Based on age and gestation.
Exactly. We also have clear criteria for when a baby needs an urgent referral to a specialist like jaundice in the first 24 hours, an unwell jaundice baby, or that prolonged jaundice we talked about.
Right.
In terms of general management, first step is always try to address the underlying cause, if one's found. And making sure the baby is well hydrated and getting enough nutrition is really important, helps flush the bilirubin out.
Good feeding helps.
Definitely.
And then there's phototherapy. That's probably the treatment most people have heard of, right? The blue lights. How does that actually work?
Yes, phototherapy, it uses special blue lights to help break down the bilirubin that's built up in the baby's skin.
How does light break it down?
It's quite clever. The light energy converts the bilirubin into a different form, isomers, which are more water-soluble.
Ah, water-soluble.
Exactly. So the baby's body can then excrete these forms more easily in their urine and stool, even without needing the full liver conjugation process. It bypasses that bottleneck, essentially.
Neat. So when you decide to start it?
Again, it's based on treatment graphs, considering the bilirubin level, gestational age, how fast it's rising, and any risk factors. We'd start it promptly if there's a rapid rise or if jaundice hits in that first 24 hours.
Okay.
And remember, premature infants have lower thresholds they can't tolerate as high a level as term babies.
Right, they're more vulnerable.
Exactly. During phototherapy, the baby is placed under the lights, usually just in a nappy, to expose as much skin as possible. Their eyes are protected with special eye masks.
Little sunglasses.
Kind of. We also need to make sure they stay warm, keep them well hydrated, often meaning regular feeds, and really encourage continued skin-to-skin contact and interaction with parents when possible.
Still need that bonding.
Absolutely. Modern LED phototherapy units are very effective and commonly used now.
Okay, and what if phototherapy isn't enough
Mm-hmm.
in really severe cases?
Yes, in very severe cases, if there are clinical signs of that acute bilirubin encephalopathy, the brain being
The
affected.
neurological signs you mentioned.
Exactly. Or if the bilirubin levels are just dangerously high, above a critical threshold on the charts, we might need to perform an exchange transfusion.
Exchange transfusion. Sounds intense.
It is more intensive. It involves gradually removing small amounts of the baby's blood and replacing it with compatible donor blood.
Why does that help?
It very rapidly lowers the bilirubin levels in the baby's system and also removes antibodies if hemolysis is the cause. It's usually a double volume exchange, meaning about twice the baby's blood volume is exchanged over time.
Wow.
After an exchange transfusion, the baby still needs ongoing care, usually continued phototherapy, close monitoring of bilirubin levels, managing them according to the guidelines.
Okay. You mentioned specific scenarios earlier, like the very early jaundice or the prolonged kind. What are the key management points for those?
Right. As we've stressed, jaundice in the first 24 hours needs urgent assessment to find those serious causes. For prolonged jaundice 14 days in term, 21 in preterm, it's crucial to ask about and look for those pale stools and dark urine.
The signs of cholestasis.
Yes. In these cases, we always measure the conjugated bilirubin level. We'd also typically do a full blood count, check blood group and DT, get a urine culture to rule out UTI, and make sure the newborn metabolic screening, the heel prick test, was done and is normal.
Right.
And if that conjugated bilirubin level comes back significantly elevated, generally the threshold is over 25 micromoles per liter. That strongly suggests potential liver disease like biliary atresia, and we'd get expert advice from pediatric hepatology straight away.
Okay, specialist input needed quickly there. So overall, what's the general outlook? What's the prognosis for babies who get jaundiced?
Generally, in the vast majority of cases, the prognosis is excellent.
That's good to hear.
Physiological jaundice resolves on its own, no long-term effects, usually gone in a week or two, even when there is an underlying condition causing the jaundice. With appropriate and timely management like phototherapy or treating an infection, the outcomes are usually very favorable.
Right.
However, and this is the crucial but severe untreated jaundice can lead to serious permanent complications. Primarily
Hemicterus again.
which causes long-term neurological damage. So early detection and treatment are vital to prevent that. And just specifically for biliary atresia, the prognosis is much, much better with early surgery, ideally in the first 2 months of life.
Time is critical there.
Absolutely.
And what exactly are the potential complications if things go wrong, if bilirubin gets too high and isn't treated? Let's talk a bit more about connectors.
Okay, connectors, as we've said, is the most serious complication. It's rare, thankfully, but devastating. It happens when bilirubin levels get extremely high, cross the blood-brain barrier, and deposit in specific areas of the brain.
What does that deposition do?
It causes irreversible neurological damage. This can result in things like cerebral palsy, significant hearing loss, problems with eye movements, and developmental issues.
That sounds awful. How rare is it?
The incidence is estimated around 0.5 to 1.0 per 100,000 live births in places like the USA and Europe. So not common, but utterly preventable with good care.
Right, prevention is key.
Severe hyperbilirubinemia itself, even without progressing to full kernicterus, needs rapid treatment to prevent these brain issues and other problems.
Are there other, maybe less severe complications?
Yes, other things can sometimes arise. Difficulties with breastfeeding can sometimes occur or be exacerbated. Dehydration can be a risk if the baby isn't feeding well due to lethargy from the jaundice.
Okay.
And sometimes infection can be tangled up in it, either as a cause of the jaundice or maybe a baby being treated is more susceptible. But kernicterus is the big one we aim to prevent.
Got it. So just to kind of summarize what we've covered today, neonatal jaundice is incredibly common in newborns.
Super common.
And mostly, it's just a normal physiological thing that gets better on its own.
Usually, yes.
However, it's really important to be vigilant, to understand the different potential causes, be aware of those risk factors, and crucially, know when to seek further medical advice.
Absolutely.
All to prevent those rare but very serious complications linked to really high bilirubin levels. This has been a really insightful deep dive. Thank you.
My pleasure. Being well-informed really is key for both parents and healthcare professionals to ensure the best outcomes.
Definitely. And if you are looking for more helpful resources, perhaps for medical revision, don't forget to check out PastMSRA.com and also FreeMSRA.com.
Great resources.
Thanks for joining us for this deep dive. Until next time, keep learning.